The work eventually was really undertaken and done at the Stebbin Hawkins Clinic and the Hawkins Foundation in Greenville, South Carolina. Dr. Hawkins is a legend in shoulder surgery, and with his team and my team out there, we were able to build an incredible program that allowed us to ask questions and then go answer them. In this particular case, we were very blessed to have a young Polish man who joined us for a year, an MD PhD named Adam Klapisz, who is the lead author on this topic. And Adam's energy and meticulous attention to detail was critical in terms of getting this project finished. He spent a year with us and had a number of projects, but this was his first one and really responsible for getting this to market. Bone loss and shoulder instability continues to be the biggest problem that we deal with in trying to get a satisfactory solution for our patients. Traditionally, the Latarjet has been around since 1954 and is an outstanding procedure, but does have some drawbacks. One is it is bone only, and secondly, it does not have a cartilage portion to it. And so the question for this particular study was, could we provide an autograft source of osteochondral graft material that might equally restore glenoid bone loss, if you will? We came across the distal clavicle as a possible autograft, and so the methods of this were to take a series of cadavers and remove the distal clavicle and prepare the graft as we had described previously, and then compare its ability compared to that of the Latarjet to restore the amount of glenoid bone loss that is lost in a 30% model. We also wanted to check and see if the articular cartilage thickness of the native distal clavicle was pretty similar to that of the native glenoid. What we found was the distal clavicular autograft was able to reconstruct more of the glenoid bone loss in our model compared to the Latarjet in every case. Further, the thickness of the articular cartilage of the distal clavicle was very comparable, within about 1 millimeter or so of the native glenoid cartilage. Thus, from this paper, we feel like that the distal clavicular autograft is a very reasonable solution when going forward in terms of replacing bone and cartilage loss normally seen in the setting of glenoid bone loss and shoulder instability. Going forward in the future, while the distal clavicle osteoarticular autograft option is very promising, we have not validated this in a clinical setting yet. I personally have done about 20 to 25 cases in this regard, and the results are very promising, but longer-term follow-up is needed before it can meet a peer-reviewed clinical follow-up study. Further, we don't know the role precisely of the sling effect that the distal clavicle does not provide that the Latarjet does. More recent data has shown that other bone grafts do well without restoring the sling effect, but again, this remains to be tested and validated both in the lab and in the clinical setting.